And we're good to go. Okay. All right, everybody. My name is Dr. Joseph Nesser, physical therapist. As Shula mentioned, I do serve New Jersey. Today's presentation is going to be about falls and balances. Usually, I do it in a format where it is a lecture component followed by hands-on screening. So at the end of the presentation, you will get screened by one of my colleagues and you will have concrete data in terms of where you fall on that level. Today, it's a little bit different in terms of format because we're doing it on Zoom. But nevertheless, we're going to cover what it is to be in a category such as falls, what puts us at a risk of falls, and some things to jog your mind and to get you started into addressing those factors. A little bit about me. I'm a doctor of physical therapy, graduated from Quinnipiac University, board certified exercise expert and for aging adults, as well as neurological rehab specialties. One of them are certified stroke rehabilitative specialist. And I do have some credentials in some evidence-based research for falls and balances for the aging adults, such as the Otago, which we'll talk about a little bit later today. So falls are very prevalent. As a matter of fact, in the United States, every second there's an individual that is falling above 65 years of age. It's the #1 cause of hip fracture, and as much as 30% of adults within the United States are reporting that they have fallen within the year. It's on the rise. These are older numbers. CDC hasn't put up updated numbers as of yet, but it's predicted to be a little bit higher than the 2016 number. It's a very expensive, it's a very prevalent and expensive cost for the United States, hence why the government is throwing literally billions of dollars at this annually. So one of the methods, one of our goals for today is to try to reduce our statistics within our own community. So we're going to try this out. I've done it on a couple other webinars, but you can shake your head, you can type in the comments yes or no, or you can just do like raise a hand or something like that. So how many of you have suffered a fall within the last year? Anybody fell within the last year? And then another thing to think about is how many of you know someone that has fallen within the last year?
Yes.
And again, it's just to get your mind going. And then as a result of that, how many of you have known someone that had a life-changing event as a result of a fall? So whether or not that be an injury, that be a hip fracture, that be a brain issue like a traumatic brain injury. And then the last thing is how many of you are afraid of falling or feel unsteady on your feet? And again, I know it's a little bit different because we're on a Zoom here, but it's just things to get your mind going. So I'm going to ask this question, the true or false? A fall only counts if you hit the ground, true or false? And the reason why I bring this up is because when I ask individuals, have you fallen within the last 6 months to a year, oftentimes they say right off the bat, no. But then when delving a little bit more into the conversation, we get, wait a minute, that was considered a fall? So the answer is it's false. And the reason for that is a fall is defined as any event that leads to unplanned events that leads to us reaching out for a supporting surface, whether or not that be a floor, a chair, a bed, etc., or holding on to somebody to catch yourself from falling. And the Hopkins Falls Grading Scale is on the right, which healthcare providers such as myself will use, and I'll get into a little bit more in depth on the next slide. But just to point out, it must not be a result of an external force, somebody pushing you, shoving you, or a medical event such as like a heart attack, a stroke, fainting, seizures, orthostatic hypotension. So blood pressure drops is a very common one as well. So when someone describes to me a fall, when we're trying to investigate a fall or try to figure out how many times this person fell within the last year, we can grade it on a scale from 1 to 4. 4 means that the person fell, hit the floor, and ended up in an inpatient, such as a hospital. A grade 3 means that they fell, hit the floor, and sought medical attention. Whether or not they were treated or not doesn't matter, but they went to their physician to get it checked out. A grade 2 means that the person fell, hit the floor, but they feel like they're okay, they're able to get up. And a grade 1, which is most common, means that a person tripped, but they did not end up on the floor. They were able to catch themselves. But again, I just want to reiterate, a grade 1, you don't need to hit the floor in order for it to count as a fall. So what happens is when an individual falls within the year, the reason why we ask this a lot as a healthcare provider is because past falls not only increase someone's risk factor for additional falls in the future, but it always puts this person within this vicious cycle. As you can see from this flow chart here, somebody falls, and more likely than not, they're going to develop this fear of falling. Whether or not it's the first time they fell, second time they fell, it really doesn't matter. They end up being a little bit more, shall I say, unsteady on their feet and more conscious of it. That fear of falling for one reason or another usually leads to fear of moving, because if I move, I'm going to fall. So I don't want that to happen. We're going to move less, decrease activity, whether or not that we stop going to exercise or the boardwalk or getting out of our house more often. Or I also see that people stop moving as much within their own home. So, oh, I'm going to save that for later. I'll save it for when my children come, or I'll move my bedroom to the first floor so I don't have to do the steps. I'll avoid it altogether. So long story, decreased activity will lead to increase in weakness. And increase in weakness, not only for muscles, but in terms of your balance systems, your cardiovascular systems, etc. That in itself poses someone at a higher risk for falls, which we'll get into in the later slide. And then it goes into this revolving endless circle. I just want to point out that the fear of falling is not necessarily imposed on the individual themselves, but it often happens where their concerned children or concerned significant other will put this fear on them to say, "Woo, I don't want you to fall, Ma. I want you to stay put, and we're gonna mitigate some of the risks by putting you on the first floor, or not going out, only going out with other people so we can reduce that risk." So it's not necessarily driven within, sometimes it's driven without, but I'm gonna refer to this chart a lot because it's imperative that we try to identify where someone falls and try to get them out of this vicious cycle. So true or false, and I'll just leave this up here for a second. Falls are a normal part of aging. You can type in the comments, you can shake your head, yes or no. But falls are a normal part of aging, true or false? And the answer is it's false. And some of you may feel like, why did I put that up there? I get it a lot. I get it a lot where people say, hey, I am older, falling's normal, but in reality, research shows that we can reduce as much as 75%, which is why it's important to cover this topic, even though it's not appealing to many, but it's important that we try to mitigate some of the risks for the future. So we go into types of risk factors when we come into a fall. I know I mentioned risk factors before, but we can categorize it into two categories, modifiable and non-modifiable. Based on what the word is, we can easily change it or not. So when we talk about non-modifiable, think age, think history of falls. Again, falling is a predictor of future falls in the future. So gender is another one. Poor vision, which is going to be a common theme, which I'm going to touch on in a few more times. Poor sensation or feelings in the legs. So think neuropathy, like diabetic neuropathy or polyneuropathy. Ethnicity is a good one. Chronic disease diagnosis. So cardiovascular, congestive heart failure, COPD, they're all been shown, and diabetes, by the way, have all been shown to increase someone's risk of a fall. And memory deficits as well, such as Alzheimer's disease. So when we get into like chronic disease diagnosis, we can't modify the disease per se, but let's try to work together to try to mitigate some of the side effects of the disease and try to reduce the risks of falls, which we can do. Going into modifiable. So those are things that we can easily change one way or another. We go into our internal and then we go external. So internal, think within. So that's physical inactivity, which we're going to touch on quite a bit because I'm a physical therapist. Leg weakness, poor balance. Again, think of that vicious cycle. Those were on there. Their increase in weakness. Those are the top three or top two that usually occur. Improper use of cane or walker, which I'm going to touch upon in a future slide in depth. Medication issues or errors. This is a big one. So research has shown that those that take more than 4 medications, also known as polypharmacy, are at increased risk of fall for one reason or another. The increase in medications we take again, we're at increased risk for side effects because as every medication has side effects, and sometimes there are complications between the two. You'll be surprised. A lot of our aging adults are on numerous medications, but in reality, there is a good shot that we can take some people off of this. In the United States, our system is that we don't have a shared system between practitioners, healthcare providers. So the practitioner only knows what you tell them. Let's say you go to two physicians. Physician A will only know what you tell them. Physician B will only know what you tell them. They don't know what the other one prescribed. So oftentimes I'll see, and I did this more recently, where someone's on, let's say, a dozen medications. I encourage them to take the medication to the pharmacist and to their primary care physician, whoever prescribed the most. And in reality, they were taking two medications that were canceling each other out because two different physicians were prescribing them. So I always urge people, take your medications once a year at least to your primary care physician or cardiologist, whoever prescribes the most, and have that conversation, go review them and say, why am I in this one? Why am I in this one? And then just see if you can either lower a dose or try to mitigate or get yourself off of medication. Low blood pressure when changing positions, this is referred to as orthostatic hypotension, is very common as we get older. We can address this. A big one with this is hydration, but we can have other means to address it as well. Poor vision, again, we're going to see this quite frequently, is a good one to take care of. Fear of falling and depression. Think about that scale that I showed you earlier in the presentation, which we're trying to get out, because usually it all starts with the fear of falling. And social isolation and depression usually goes hand in hand, and we've seen a lot of this over the pandemic as well. Some of the external risk factors. So we're going to see medications here as well, because sometimes we can get off some medications. Sometimes it's a life-saving drug, so we need it. But again, that polypharmacy that I mentioned previously, we should be taken care of. External risk factors, more or less, think about the things in your environment, within your home or your environment that you can change. So a big one we see is throw rugs. They may look good, but they may not be placed in the ideal position, or there may be a safer way to secure them to the floor. Stairs, uneven surfaces, poor lighting is a very big one, especially the path between your bedroom and the restroom. So think about that when you go into the restroom at 3, 4 o'clock in the morning. Ideally, it should be lit with a night light in between, so you don't have to guess where you're going. And then as we get older, the vision systems in our body don't react to light as well as quick as they should. So that's why the night light is a great idea. Narrow doorways and paths is very, very interesting. I encountered this yesterday, as a matter of fact. Somebody mentioned that having an obstruction within the pathway, they put a chair with a throw rug in the pathway, in the door frame, was the new in thing to do. But being able to navigate that tight path is very tricky, so it may not be ideal. So how can you prevent the fall? I will email whoever wants a checklist we can do. Basically, it's a questionnaire of 14 questions. You take it, you score it, and then if you scored 4 or more, it means you should have a conversation with either your primary care physician or a physical therapist, and we can help do further screening, further testing, and see how we can reduce your risk. But this brochure, which I can email everybody, basically allows you to get the first start to say, okay, am I on the radar for falls in the future or not? So let's say someone is a risk for falling within the future. Some of the things we can do today, the theme is be more active. Don't move less, move more. Even though you may feel unsteady on your feet, we can modify your activities to keep those systems going, because the less we move, the less we're gonna be on our feet later in life. So it's like you use it or lose it type of thing. It really holds true. Making our home safer, like I just discussed a couple of seconds ago, we can do a home assessment, which we'll get into. Optimize vision and footwear. Again, vision is a very big theme. Go to your practitioner, get vision. The reason why we always emphasize vision is because it's one of the 5 systems that keep us upright. Footwear is a big one, especially individuals with like polyneuropathies or neuropathies from diabetes. So footwear is a very big one as well. Medication review by pharmacists, which I mentioned previously, the cane or worker using assisted device. if prescribed to you, which I'll get into a little bit, and going to a community class or physical therapy for strengthening, balance improvement, and decrease of fear of falling. Again, those three that I mentioned are on that vicious cycle, which I mentioned in the beginning, and that's really the theme. So when in doubt, get it checked out. So physical activity, as a practitioner myself, I have to give the caveat, if somebody does have an extensive past medical history, especially cardiac, especially kidney issues, it's highly recommended you just go to your primary care physician or your physical therapist and let them prescribe an exercise program for you, or let them give you parameters. So it's not uncommon where individuals tell me they want to do a Zumba class or something similar, but they want me to give them parameters in what they can work at within a safe zone, so they don't have any adverse events. Go to a PT. If somebody has, I just put this in here because if somebody has dizziness, strength, balance, or any issues of fear of falling, get that addressed prior to going to a community class. And the reason the reason why I mention this is because oftentimes I'll get individuals years later where they'll tell me, oh, I used to go to the community class at the J or SBH or DSN or a Zumba class, but I stopped. And when you delve into that conversation, why they stopped, a lot of it had to do with either they were dizzy during the class or the fear of falling, or they just couldn't keep up. So best to get those systems fixed, get a modified program by somebody, either the class instructor or physical therapist, so we can keep you in that class and keep you happy within it. I mentioned on the first or second slide of this presentation that there are evidence-based fall prevention programs available. I myself specialize in two of them. One's the Otago. Last I checked, if the program was carried out correctly, it can reduce risks of fall risk as much as 50%. So put it in Google. I could also email the group of the programs you're looking for, but that's a very good program to keep in mind. So getting into the external modifiable risk factors, we look at the environment. The CDC does put out the study program for the Check Safety brochure, which I can email everybody. It basically allows you to go through your house. It's kind of like a checklist, and it prompts you for things around your house to identify and potentially minimize. So a big thing is like removing fall hazards within the home itself. Throw rugs, like I mentioned, is a very, very big one that we see a lot. You can do this on your own if you want a professional like a physical therapist to do it for you. We do home assessments all the time. Feel free to reach out to your local physical therapist, and I myself do them quite a bit. So getting into assisted devices such as a walker and a cane. So I myself, my philosophy is that ideally it should be temporary. But if it's prescribed to you, it's highly recommended that you need it and you should use it, even if temporarily, just to get you through that period of time. At least half of older adults that were prescribed a cane, or actually 75% of the older adults that were prescribed an assisted device that fell were not using it at the time, which is significant. It's interesting to know about half our older adults were never properly measured or fit. I love to ask the question, where did you get this assisted device from, and who prescribed you the cane or walker? And the most common answer I get is that they found it on an infomercial at 2 o'clock in the morning, or they got a catalog in the mail and big bold letter, it said Medicare will cover it, so it's free. In reality, if you're not using the appropriate device, it can put you at a higher risk of a fall. And if it's not properly fit or properly used, it can put you at a higher risk for a fall. So best to just, even if it's for one visit, contact your local PT and let them either adjust it and give you their opinion on what device you should use, if any. It's important to note that we discussed the risk of falling, right? But it's important to note that it's very dynamic. It can change in a month, it can change in 6 months, it can change in a year. The reason why the risk of falling is dynamic is because as we get older, our systems are a little bit slower than and quick to adapt as youngsters. So something as simple as a change in medications, and a big one is Flomax, which I see often, where if somebody starts, let's say, Flomax, the first 5 to 7 days, it's not uncommon for them to feel lightheaded, dizzy, and unsteady on their feet. A big thing is also a change in health, right? We've seen a lot of individuals with about a CHF exacerbation or, let's say, COVID, where they're just not feeling right, they're not moving right, they're feeling very achy, very weak and unsteady, which can also increase their risk of a fall during that time period as well. Recent reduction in activity level, again, please don't stop moving. If you get anything out of this presentation, it's just move more, not less. A change in vision prescription, because that is one of the systems that keep us upright. I put this in here, move to a new home. So research has shown that those that moved into a newer environment within the first 2 to 3 weeks puts them at a very high risk of a fall. And the reason for this is because if you close your eyes and you can visualize your home environment with your eyes closed, if it's your steady home environment, you know the nooks and crannies of the floor, you know the nooks and crannies of the room, you know the height of the step, you know the depth of, let's say, the door jamb, and you know the width and length of each room. However, those that go to a new home, you really don't have that ingrained in your memory as well. You don't have that muscle memory within your brain. So think about it, those that go to, let's say, Florida, to Jersey, to Brooklyn, back and forth, just be mindful for the first couple of weeks when you're in that new environment. So God forbid, if a fall occurs, my biggest recommendation is don't get up right away. Do a self-assessment. Are you in any pain? Are you lightheaded? Are you dizzy? Are you bleeding? The big thing is you have to check for injury prior to getting up. If you are injured or if you are in extreme pain, highly recommend you call either Hatzalah or a medical emergency system to get you help and just give you a once over. If you did hit your head, you have to go get checked out because we want to prevent any adverse effects of that. My recommendation, I've seen this quite a bit, where individuals try to get up when they know they don't have enough energy to do so. It's highly recommended. If you feel that you don't have the energy, option A is to rest until you do get the energy, or option B is, again, call for help. Real quick, I had an individual where he fell on the floor. He knew he didn't have the energy, very big guy, but he attempted to get up. Halfway through, he fell down. This repeated 3 or 4 times. By the time I seen him, he had quite a bit of fractures and broken bones because of that, because he kept on refalling on a already an injured. Another tidbit, go to your local physical therapist. We can teach you how to try to fall as safe as possible, as well as techniques to get up and on the floor and off the floor to standing up. So we can train you, go to your local physical therapist, and we can do that for you as well. I added this slide because more recently it was brought to my attention. Not everybody is aware of the ins and outs of the life alert systems or medical alert systems. It's important to know that some of these systems have what's called home coverage versus roam coverage. Home coverage means that the device, you can click the life alert per se, the device, and it'll cover you within your home only. Roam coverage means that the device will work within your home and on the road outside of your home. So it's important to know which coverage you get, so you have your options when in home or outside as well. Nowadays, it's very inexpensive to obtain something like a smartwatch where the watch itself can detect a fall, and it can prompt you to call emergency services. So you have it with you, can just swipe the right. And some of them are fancy where it should notify your emergency contacts that, hey, so-and-so had a fall, check up on them. So it's a really neat device. Last but not least, smart devices such as an Amazon Echo Dot is amazing. It's a very inexpensive tool, but it can be the safest thing within your home. A lot of times, and I had this yesterday, as a matter of fact, someone had the life alert system, but I've seen them take it off during the session. And I prompted her and I said, why'd you take it off? And she's like, it was bothering me. So believe it or not, a lot of us rely on it, but we take it off sometimes. A lot of us don't have the life alert, and we promise ourselves that we'll keep our cell phones on us at all times. But in reality, there are going to be gaps within our little system there where we don't have a means of communication. And God forbid, if somebody falls, it's going to be very challenging to get assist if we can't get ourselves up and call somebody. Amazon Echo is a great device. It's under, I think, $25 these days. You can put two around your home, and it allows you to call, say, Alexa, call 911, or Alexa, call so-and-so. So you don't have to get up off the floor if you can't. So in summary, we spoke a lot about that aging adults, one way or another, are at an increased risk of falling. It just depends on which level we are at. It's important for us to know where we're holding on the full risk scale, not to make you nervous, but so you're aware of it and we can get it addressed when you are ready. Risk factors can be modified. So one way or another, I have people that tell me, wait a minute, I'm always going to be a high risk of falls. I'm always going to fall. And the case is, it's not necessarily true. We can mitigate the risks, whether or not that's falling once a year or falling once every 2 years, but we mitigate risk one way or another. It's important to have your eyes checked at a minimum once per year. Oftentimes I see people using the same prescription for years on end. And it's important just to keep moving, right? Keep exercising, improve your balance, keep those systems going. So we're good to go. Now, let's make an action plan. The best thing is to start with one thing, right? So if you leave this presentation, if you get two things out of this, the first thing is take the initiative. Do one thing, either contact your pharmacist or a doctor to review medications, or contact your physical therapist. Let them do a home assessment. Let us screen you for balance. Let them tell you where you hold on the scale. Whether or not you want to commit to working on it now, it doesn't matter. But at the end of the day, it does matter that you should know where you fall. So when you're ready to make that change, we can help you. And make a goal. Example would be to contact a friend, right? You can do exercise within your home, and you can even do it on YouTube. I've given people exercise programs like Go for Life, which the government puts out for free on YouTube. And get a friend, be accountable. Even if you're not technologically savvy to do it on Zoom together, put each other on speaker and just keep on moving. You can also go through the checklist, which I can give you. I could send the group after this presentation, those 3 checklists as well. And then when in doubt, get it checked out. And I just want to let everybody know that insurance will cover a yearly checkup and a tune-up. So just like you go to your primary care physician to get an annual checkup, you should be going to a physical therapist once a year to get a checkup to see where you're falling, to see where you are in relation to someone your age and gender. And if there's anything that you got out of this, it's move more and not less. So remember, just keep on moving. Don't stop moving, everybody. If you want today's handouts, you can feel free to email the office, contact the office, we're Propelled Rehab, or you can touch base with Shula, and then we'll be sure to get them out within the next day or two. And does anybody have any questions for me? You can either send them to Shula, you can do it in the chat, you can turn your mic on.
Does anybody have any questions? You can unmute yourselves. Anyone? I can't see a lot of your faces because your video's off, but if you have any questions for Dr. Nesser, please.
I must have done a good job.
Yeah. Ask away.
If you decide that you want to do it on a more private platform, you can also reach out to the office as well, and we can discuss it on an individual basis. I know sometimes people don't like to discuss health issues or personal issues on open platform.
Or you can write it in the chat anonymously, and I'll ask the question for you if you feel more comfortable doing it that way. Don't be shy. Anybody? Nobody.
That's good.
Okay. I did record this for whoever wasn't able to attend. I hope that's okay, Dr. Nesser.
Yep, it's all good.
Okay, awesome. If anybody does want the slides please unmute yourselves and give me your email address, and I'll be happy to email it over. Anyone? Nobody? Okay. Yeah. Okay, somebody messaged me they want the slides.
And again, Shula, you could just shoot me an email and then we'll get it out to everybody.
Yeah, sure.
You ready?
Okay, perfect. Thank you so much.
You got it. Everybody keep on moving.
Thank you, doctor. Very good
Sounds
presentation.
Thank you. Thank you. Everybody have a great day.
Thank
You
you.
too.
Thank you.
Be safe.
There's a few people that I don't have names for.
Okay, sure.
Rachel, what's your last name?
Cohen.
Rachel. Okay.
Rachel. Rachel
And
Franco.
oh, how are you?
Okay, how are you, Shula?
Good, good. Thank God. Long time no see.
Yes.
Okay,
Very
awesome.
good. Very good presentation.
Yeah, he was great. He was great. And Marty, what's your last name?
Mizrahi.
Mizrahi. Okay, awesome. And Joy, what's your last name? You can unmute yourself with that. And if any of you want the slides, I can email them to you.
Yes, I would like it. Can you, shall I give you my email address?
Yes, please.
Okay, it's Rachel, RACHEL
Mm-hmm.
dot Cohen, COHEN
Yeah.
49 at iCloud.com.
Okay, great. I didn't know you had Zoom. I'm so happy.
Yeah.
Okay, because we've been having programs all year. So I don't know. Did you come to a few of them?
I did. What was the last one? I forgot the last one. I went to the exercise with the new teachers. That was great last week.
Oh, you did? Oh, okay, great. Yeah, she's awesome.
I wish you could do exercise more often.
Maybe we will in the summer. Maybe we'll have it every week because knitting usually dies down in the summer. So
Yes.
So yeah, and she's in Jersey, so maybe we'll have that every week.
But she was great. It was great. It was very good. I enjoyed
she
it.
was awesome. She was.
Yes.
Oh, okay. I didn't know that was you. Okay, I'm so happy.
That's how you been? How are you feeling, Shula?
Good. Thank God. Here,
Hanging
working, trying to figure out the next steps. You know.
Yes.
Yeah. There's someone's phone number 347. Do you have a name? Sorry, just for attendance wise. Oh, let me.